Hello, good morning. I'm Ashok Kurokade, Consultant Radiologist and Endoscopic Surgeon from Winchester and the University Hospital Southampton, UK. I welcome colleagues from around the world on behalf of our organizing team to this inaugural Winter Global Radiology Endoscopic Sinus and Anterior Surgery Webathon. Global Radiology Network is a registered non-profit organization with a mission to foster surgical education in radiology and skull-base surgery. We have successfully hosted annual multi-center live surgical webcast, The Lioness, since 2014 in collaboration with Lion Foundation. Thousands of surgeons from all corners of the world have benefited from it. More than 2,000 surgeons from 110 countries have registered for GRACE 2020. We will have hugely informative and engaging sessions presented by eminent radiologists and skull-base surgeons from around the world. GRACE 2020 is hosted at the Global Telemedicine Studio of Professor Wilco Groneman in Utrecht in Netherlands. It is supported by Medtronic and Karl Storz. Thank you.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients with technology customized to your unique clinical and facility needs? Introducing Stealth Station Flex ENT Navigation System, a customizable system from Medtronic ENT, a market leader in image-guided surgery technology, featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
Mr. Dr. Timothy Beale, he's a consultant radiologist from London. He's already logged in, and he will be presenting on sinus radiology. So if you just hold on for a minute, we'll get, okay. Hi, morning, Tim.
Hi, so I look a bit rough. Thank you very much. It's a bit early, but lovely. And thank you for the invite. I'm just going to talk about clinically relevant sinonasal anatomy. And it's actually, the importance of anatomy has been known for about 500 years. If you look at this quote from an English surgeon, but chiefly the anatomy you ought to understand if you will cure anything that you do take in hand. And I was involved in this rhinology, a European position paper, and there's a link to it there, which has the update on the sinonasal anatomy at the moment. So what is the clinically relevant anatomy and variants? I think
Tim, can you share your screen?
Can you see that now? Is that shared?
Thank you.
Yes.
Sorry about that. So just to say that anatomy has been important for 500 years. Here you see the quote from the English surgeon, chiefly the anatomy you ought to understand if you'll cure anything that you do take in hand. And there's a link to the European position paper on terminology of sinonasal anatomy. So the clinically relevant variants, I think, are those that increase your surgical risk, alter the pathways of drainage, and also change the surgical planning. I think when you review, you've always got to look in 3 planes and get them to reconstruct also on soft tissue window settings. I'll explain why later on. If you're unsure where the anatomy is, then put a marker on it. So for example, here is the Uncinate process on the coronal sequence. if you look on the axial sequence, you can see the crosshairs, you can see where it is there, and there it is on the sagittal, and you soon get to know what the anatomy is in each of the different planes. But we're going to talk about the drainage pathways first. First of all, the anterior osteomeatal unit, or the osteomeatal unit, and then the sphenoethmoidal recess, or the posterior osteomeatal unit. So the anterior osteomeatal unit, I know you know, drains the frontal ethmoidal, anterior ethmoidal, and maxillary antrum on the same side. So here's the ostium, here's the ethmoid infundibulum, there's the hiatus semilunaris, this is the middle meatus, there's the frontal sinus opening, and this is the drainage pathway, the more distal frontal sinus drainage pathway. And all together, that's the anterior osteomeatal unit, best demonstrated on the coronal reformatted images. And the key components of this anterior osteomeatal unit are the ethmoidal bulla, the uncinate process, and how it affects the drainage pathway. And I think it's key because that's the commonest operation you perform, an uncinectomy, maybe progressing to a middle meatal antrostomy. So here's the bulla, here's the uncinate process, and there's the mucociliary pathway draining supraimmediately out of the antrum. So how do you recognize this uncinate process? Well, there it is on the coronal image. There's the crosshair on the axial image, and there it is on the sagittal reconstruction. So it's part of the ethmoid, it's sickle-shaped. You have that free posterior border, and there are many variants. This is what makes sinonasal anatomy so interesting. We're all different. And what are the most important variants of this uncinate process? Well, I think how far they are from the medial wall or junction of medial wall and floor of the orbit. Also the superior attachment of the uncinate process, because that will alter the frontal sinus drainage pathway. So I'll give you examples of the distance between the uncinate process and the orbital wall. This is the most common variant, where you've got the uncinate process, you've got the ethmoidal bulla, we saw that before, and you've got a decent distance between it and the junction of medial wall and floor of the orbit. There should be little risk to the orbit in this case. But what about this patient? You have a coronal on the left and an axial on the right scan, and you can see that the walls of the right antrum have all been sucked in. And why is that? Well, there's the uncinate process. It's touching, it's flat against the orbital floor, and you've got an atelectatic infundibulum, and of course you have the risk of orbital damage. The orbital floor is descended, and also the uncinate process abuts it. This is silent sinus syndrome, and it doesn't necessarily have to be an aerated sinus. Here's a completely opacified antrum. You can see that all the walls have been sucked in, the orbital floor is descended, and these people present with enophthalmos, hypoglobus, a low-lying globe, facial asymmetry, and this is maxillary atelectasis. It's idiopathic. It's the 3rd to 5th decade usually, and it's due to negative pressure in the antrum, and the treatment, as you know, is antroscopy and surgical correction, which has its risks. But there are variants in the shape of this uncinate process. Sometimes they may be pneumatized, as in this case, on both sides, and then it can look like a polyp. Here it's averted, and note the paradoxically curved turbinate above it. Here the uncinate process is horizontal, and that's usually due to a large overlying or posterior superior ethmoidal bulla, and this is the more common variant. So these are different shapes of the uncinate process you have to be aware of. What about the superior attachment of the uncinate process? And that alters the drainage pathway of the frontal sinus. So is it medial? So is the uncinate process medial or lateral to the frontal sinus drainage pathway? So here we have the uncinate process on the patient on the left, and it's attached to the aginasia air cell, which is in A. On the right-hand side, the uncinate process goes and attaches to the anterior skull base, a risk of damaging that. On the left-hand image, the frontal sinus drains medial, and on the right, lateral towards the ethmoid infundibulum of the antrum. Notice also on the right-hand side, the uncinate process here attaches to the medial wall of the orbit, and there is the terminal recess, a blind ending area. A drainage pathway here is medial to the uncinate process, but it also may be attached. Here's the uncinate attached to the middle turbinate, and again, the frontal sinus drains lateral to the uncinate process. What about the ethmoidal bulla? Are there relevant variants? Yes, of course there are, like in the whole sinonasal region. So you have the ethmoidal bulla labeled to B, and it's variable in size, occasionally multiple, and it forms the anterior face of the bulla, forms the posterior border of the semilunar hiatus. So here's the anterior border of the ethmoidal bulla, here's the uncinate, and there's the hiatus semilunaris. If the bulla is small or non-pneumatized, the orbit's at risk, and if it extends to the skull base, then the anterior skull base may also be at risk. What about the frontal sinus drainage? Well, I think this is best seen on the sagittal reconstructions, although you often have to look in multiple planes. So there's various questions. Is there a frontal sinus ostium? Well, no, it should be called an opening because it's formed by whatever adjacent ethmoidal air cells have grown into that region. Is there a nasofrontal or frontal nasal duct? No. And what is the frontal recess? Well, the definition is disputed, but it's the anterosuperior part of the ethmoid inferior to this frontal sinus opening. And the more distal drainage, frontal sinus drainage pathway is different from the frontal recess, but sometimes the terms are used synonymously. So let's look at the frontal sinus drainage pathway. We have the drainage pathway here, and you can see that's on the coronal. Here it is on the axial, and there it is on the sagittal between the angionasia air cell and the ethmoidal bulla. So you can see the opening, narrowed opening, and then a more distal drainage pathway. Best seen on the sagittal, but confirmed on the other sequences. What about the angionasia air cell? That means nasal mound in Latin, and it can be variable in size. So in this patient, the angionasia air cell we've labeled with this star. So the right-hand angionasia air cell in this patient is larger. And if you look on the sagittal reconstructions, you can see the frontal sinus opening is posterior to this angionasia air cell. And you can see mucosal thickening within that. So in order to drain this frontal sinus, you presumably would have to go through that angionasia air cell. And this white arrow is pointing to the nasal beak, which, as you know, can be variable in size and may need to be shaved off in order to freely drain the frontal sinus. The frontal ethmoidal region is, I think, fascinating. Now, there's all sorts of terms for this. There's Kuhn air cells, labels 1 to 4. I think the best way of describing it is knowing what it does to the frontal sinus drainage pathway. So, is the air cell antero-inferior and the drainage posterior to it, or is it posterolateral or anteromedial? You have to look in all three planes to work out where the frontal sinus drainage pathway is, because you can have anterior ethmoid air cells going to the frontal sinus. Some people call those supraagionasi, or you can have posterior ones. Some people call those frontobullar or suprabullar air cells. But I think the best thing is for them to be described where they are in relationship to the frontal sinus. Which part of the frontal sinus do they go into? So, for example, this patient, you can see a dependent fluid level in the right frontal sinus. And here is the frontal ethmoidal air cell extending into the anterior and inferior aspect of the sagittal sinus, with the sinus opening posterior to it and the opacified drainage pathway. So this is where the air cell is. It's above the agionasi. You could call it a supraagionasi, but I think best to describe where it is. What about suprabullar air cells and suprabullar recess? Well, here's the ethmoidal bulla, there's the drainage pathway, and this is an air cell above the ethmoidal bulla, and it's called a suprabullar air cell. Sometimes the frontal sinus extends all the way back above the ethmoidal bulla. This is the agionasi, and you've got free space here. And that's at risk because the ethmoidal artery may pass on a pedicle through that region and be very vulnerable to surgical trauma. So just be careful. And if that recess extends laterally above the orbital roof, then you can call it a supraorbital recess, but mainly describe where it goes. What about the antral anatomy and the variants? Well, here we have two coronal images in two different patients, and we can see infraorbital air cells. The definition there, inferior to the orbital floor, but lateral to this line of the lamina papyracea. So here's the lamina papyracea, and here are infraorbital air cells. And surgeons can get lost in it, or you may perform an inadequate anterostomy. It may confuse the anatomy, so you need to point that out in the report. Here is another patient with a larger infraorbital air cell in the supramedial antrum. This is another antral variant that is important to point out. This is the infraorbital nerve canal. On the sagittal, the anterior aspect often goes through the antrum on a pedicle and is at risk of trauma. It's very common and needs to be recognized. Here is a patient with an infraorbital nerve canal extending through the antrum. They happen to have an inverted papilloma which is attached to it, hence the hyperostosis. So not only does the infraorbital nerve extend through the antrum, but the inverted papilloma happens to be attached to it. So that needs to be carefully mentioned in the report and discussed with the surgeon. What about these accessory sinus ostia? Well, they're anterior and posterior, and they may be multiple. I think the interesting thing is that what percentage of people have them? There's an anterior, there's a large posterior. Well, if you have chronic rhinosinusitis, maybe up to a quarter of the patients will have these accessory ostia. And they may be quite large, up to a centimetre in size. And if they're not noted, you may result in an inadequate antrostomy. Anterochoanal polyps, as you know, extend through these accessory ostia. Here's a small polyp in the antrum extending just through one of these accessory ostia into the middle meatus, and then they extend posteriorly through the choana into the postnasal space. Another variant of the antrum is the very hypoplastic antrum. So on the right-hand side, this is the antrum, and there's the antrum, even though the outflow is clear. And on here, there's a very small hypoplastic antrum with a markedly thickened wall. I think the important thing with these is to ask, have they had previous surgery? Look for the Caldwell look defect. It's a rather old operation, but look for that defect because that often causes the antrum to shrink down. The sphenoethmoidal region is also fascinating. We'll talk about the anatomy and the variants in this region and do some clinical cases. Well, the sphenoid anatomy, it looks, I think, like a pterodactyl. It has a body, it's got two wings and these two pterygoid plates and very variable pneumatization. So the pneumatization may extend all the way into the greater wing of the sphenoid, under the middle cranial fossa, or down into the pterygoid plates. It's very variable. What about the drainage pathway? Well, you have the sphenoethmoidal recess and the sphenoid ostium. I think we'll talk about the ostium to begin with. So on the sagittal, the coronal, and the axial, you can see the whole of the ostium. If you put a cross on it, you can see it in the other planes. But it's variable. Most people, it's medial to the superior turbinate, but in a certain percentage, a small percentage, it's lateral. And the sphenoethmoidal recess is that bit in front of the sphenoid, medial to the superior turbinate. And if we do that, this is in the red, the sphenoethmoidal recess in front of the sinus ostium, and there it is on the axial sequence. There are lots of variants in this region, some very clinically important. So these are all coronal CTs through the sinus, sphenoid sinus chambers. There is the Vidian canal, which may be on a pedicle. This is the V2, the maxillary division of the trigeminal nerve, which may be on a pedicle, and again here, and dehiscent. And here, very importantly, are the optic nerves, which are passing through the sphenoid sinus. On the axial sequence, you have the intersinus septum. Here it is attached to the internal carotid artery, and pulling that off can obviously traumatize the ICA with catastrophic results. Again, here is the optic nerve extending through the sphenoid sinus chamber and at risk. Then there are the sphenoethmoidal air cells. These are posterior ethmoidal air cells which develop superior or extend superior or supralateral to the sphenoid. And you've got to recognize the cruciform appearance, this cross-shaped appearance here with the posterior ethmoidal air cells on top and the sphenoid below. And it may be, this air cell may be unilateral, as in this case, or bilateral, as in the middle image, and may extend, importantly, to the anterior clinoid process. The inferior sinus is the sphenoid sinus always. So what about the aerated anterior clinoid? These are two patients with aerated anterior clinoids, but sometimes it's from the sphenoid sinus chamber, as in this patient, and sometimes it's from the sphenoethmoidal air cell, as in this patient. And there's this important area called the optico-carotid recess, which is in the posterolateral wall of the sphenoid between the optic nerve and the ICA below. And when you have this aerated anterior clinoid, the bone overlying the ICA may be dehiscent in a quarter of patients. But importantly, the optic nerve may be dehiscent in 80% of patients or completely exposed. So you need to note the anatomy in that region when you have an aerated anterior clinoid. This patient, the sphenoid sinus may extend all the way up to the posterior wall of the clivus, and therefore if you have pathology in the sinus, it may erode the posterior wall of the clivus and extend into the posterior fossa, or it may erode superiorly into the sella. This patient, just some cases, presented with headaches. This is an axial image. You can see the opacified sphenoid with the osteotic reaction around it and some soft tissue in the sphenoethmoidal recess. Is that in the sphenoid or is that in the sphenoethmoidal air cell? Well, if you look on the coronal image, there are the sphenoethmoidal air cells above it. Here is the opacified sphenoid with the bony thickening and the calcification within it, most likely due to fungal disease. If you go posteriorly, you can see the bony thickening of that sphenoid. And if you look in all three planes, you can see the opacified sphenoid and the polypoidal soft tissue extending into the sphenoethmoidal recess. This patient presented with sudden onset of right-sided visual loss, and this is the T2 weighted image with fat saturated, so the fat is dark, and to all intents and purposes it looks clear, even the anterior clinoid. But if you look on the T1 and the post-gadolinium sequences, you can see that this right sphenoid sinus chamber is completely opacified. And if you look on the coronal sequences post-contrast, the optic nerve is right in the middle of between this anterior clinoid and the right sphenoid sinus chamber. And if you look on CT, you can see the eroded, here's the optic nerve, you can see the eroded bone, here's the anterior clinoid, eroded caudal aspect. On the sagittal, you can see the bony erosion and the high attenuation in keeping with fungal disease. This patient had the fungal disease taken out, the vision came back, and exactly the same thing happened when it recurred 18 months later. There's the fungal disease in the sphenoid. This patient presented with headaches and numbness in the left cheek, and they organized a CT head. You can see a massively pneumatized sphenoid that goes into the greater wing of the sphenoid. And in the middle of this is the V2 nerve canal, exposed and dehiscent, and that's the reason in this patient why they had numbness in the left cheek on the V2 division, because of the sphenoid sinus. A final case with the sphenoid is this axial image through the brain, and you can see this high signal here, and it looks to all intents and purposes like a simple polyp, but if you look very carefully you'll see the brain herniating through the lateral wall of the sphenoid sinus, and this is a meningoencephalocele. So if we look at the anatomy here, you may have a defect in the lateral wall of the sphenoid above the V2 canal. This is failure of fusion of the greater wing and the pre-sphenoid part of the sphenoid, and it's a site of weakness. And always review this area in patients with a CSF leak. So this patient has a defect there. This is a meningocele with a tiny bit of brain popping into it. This is a cisternogram. The patient's lying prone. They've had contrast injected in the back and they're tilted. So the contrast goes into the CSF, and you can see the CSF leaking through this defect in the lateral wall of the sphenoid. Common in middle-aged women who are obese and with arachnoid granulations, they can extend erode into the lateral wall of the sphenoid. Finally, near the nasal cavity, we all know about these turbinates, which may be very large and aerated, the bullosa, and they may even be in the inferior turbinates. And the paradoxical curvature is important to mention because it can look confusing when you look, and it can look like an inflammatory polyp. Septal deviations are very common. There's the chondrovomal deviation, there's the prominent septal spur, or the septum itself may be aerated. There's also important variance to the roof of the nasal cavity in the anterior skull base. Again, there are classifications. There's the well-known Kiros classification. Just to go through the anatomy, you've got the ethmoidal roof, you've got the lateral or the vertical lamella, you've got the cribriform plate, and the crista galli. The depth obviously is important to mention if it is deep. I think measure the depth. You can mention what KROS classification it is if you want. I think the importance is it asymmetrical? Is the cribriform plate lower on one side than the other? The anterior ethmoidal artery canal is very important. It's a branch of the ophthalmic, and it may be dehiscent and pass below the ethmoidal roof. And here it is. You can see it on all patients in the coronal plane. And then once you've seen that in the coronal plane, you look at it on the axial and then on the sagittal. Here you can see it on the sagittal, hanging on a pedicle within a suprabullar air cell at risk of trauma. You also got to recognize once you've operated on these patients, what does it look like? How does it alter the anatomy? Does it increase the surgical risk? And how may it alter your further second surgery? So this patient's had the middle meatal antrostomy and the bullectomy. So they've had the bulla removed on this side and a middle meatal antrostomy. This patient's had an inferior meatal antrostomy, rather old-fashioned. And you can see here the Caldwell look approach, but there's still mucosa in the ethmoid infundibulum. What about in this patient? Got a coronal, sagittal, and 2 axial scans. What have they had done? Well, they've had a draft 3 modified Lothrop, so they've taken out that bit of the septum, a large amount. They've taken out the floor of the frontal sinuses, the intersinus septum, and in fact, in this patient also the medial wall of the maxillary antrum. So there's a widely patent frontal sinus drainage pathway on the sagittal recons. And in this patient, what have they had done? Well, they've had a transsphenoidal hypophysectomy. So there's the posterior superior septum, the floor of the sphenoid, the intersinus septum, and there's the defect in the cellar floor, okay, where they've approached the pituitary. Sometimes it's very, very confusing. So these are 2 different patients. What have they done here? Well, they've had a Caldwell look, large defect. There's an inadvertent defect in the medial wall of the orbit. What's that? Well, that's actually the inferior turbinate, which is now attached to the medial wall of the orbit. In this patient, they had thyroid eye disease and a thyroid wall decompression, and the orbital floor has collapsed down. The orbital contents have collapsed down into the antrum, right into the floor of the antrum on this side. So this is orbital fat down to here. When you review the sinuses, as I said right at the beginning, review on bony and soft tissue windows to avoid missing fungal disease, orbits, pre or retroantral extension, which makes it a more aggressive pathology, and also a postnasal mass. They may present with nasal obstruction, which you may think is due to septal deviation or polyps, but if they've got a nasopharyngeal carcinoma, that's obviously the important thing to point out. And also to any inverted intracranial pathology, which may be the cause of the symptoms. Also on the bony windows, always look at the teeth, the petromastoids, and the TMJs. I asked one of my professor colleagues if they looked at the reports, and they said they didn't really look at the reports, but they were very interested to know what was happening outside the sinuses. So I always look very carefully outside the sinuses as well. So this patient has got a pacified frontal sinuses, but if you didn't look on the soft tissue, I know it's a noisy image because it's very low dose, you would miss this big epidural abscess. What about in this patient? An almost completely opacified antrum. There is the curvilinear calcific density, which tells you this is a radicular cyst, and there is the abnormality of the root of the underlying molar. So this is a dental cause for the left antral mucosal thickening. What about in this patient? This patient had nasal obstruction. Yes, they did have disease in the antrum, but the main pathology was this large mass in the postnasal space and also the nodes in the posterior neck. So this is the nasopharyngeal pathology, which needs to be highlighted. So the takeaway points are: review outside the sinonasal region and not just the sinuses. Look on the bony windows at the teeth, the TMJs, the petromastoid, they may be the cause of the symptoms. And on the soft tissues, the postnasal space, the orbits, the pre and retroantral region, and the brain. And if you don't know the anatomy, put a marker on it and review in 3 planes. Talk to your clinicians and your radiologists so the report is helpful and not just a list. And enjoy the challenge. Is the opacified sinus a frontal sinus or a frontal ethmoidal air cell? And where has the frontal sinus pathway been displaced? Thank you very much indeed.
Thank you, Tim. That was a wonderful talk, very useful. So Tim had a very significant contribution to ENT and especially rhinology. He was a radiology advisor to a European position paper and also on management of the malignant lesions. He is vice president to European Association, European Radiology, Head and Neck Radiology Association. So thank you very much. That was really useful.
Stealth Station ENT, the advanced image guidance system for the full range of navigated ENT procedures. Engineered with you in mind, based on decades of scientific, clinical, and engineering expertise, we're expanding what was previously possible with image-guided surgery. Flexible and elegantly designed, Stealth Station ENT streamlines the workflow so you can maintain focus. The flat, under-the-head emitter allows for an efficient setup. Its design allows for a large EM field. Easily find your patient's exam through a variety of network options, super speed USB or optical disc. The visualization and modeling features give you the perspective you need. Leverage data from multiple sources to create high-resolution 3D images. View structures and pathology with high fidelity. Registration expertly matches the three-dimensional positioning of the patient with the preoperative images used for navigation. Patient registration combines registration methods and provides numerical and visual accuracy feedback. Leverage the latest technology for advanced surgeries. See more, do more. The result? You have an image-guided perspective like never before. With Stealth Station ENT, you're at the forefront of ENT surgery. You are Stealth.
The question to you, Tim, is often when you do it's a rather technical question. Often when you do a CT scan, we find that it may not be compatible with the surgical navigation systems that are used. So we have to get a specific CT scan done for that. So what are the technical requirements? Can you advise on that?
Can you hear me?
Yes, we can.
Yes, so, yes, I think most modern CT scanners are of high enough resolution. You have to ask the individual manufacturers of the guidance systems, but providing you cover the whole area so they can put markers on the sites of interest, then most modern CT scanners have enough detail that we haven't had an issue with that, providing you cover the right volume. Our routing protocol could be used for nearly all the navigation systems, as far as I'm aware. We don't really change our protocol for that. But I always, when we started doing it, you have to talk to the manufacturers and ask exactly what they want. We're also starting to use cone beam CT for sinuses because that reduces the dose further. And that has a higher resolution. So it's been used for dentistry in the past, but we're also using cone beam CT because the dose is usually there if you're careful. I'm not sure that answered it well.
Okay. Yes. Thank you. That was really useful, and thanks for joining us. And
it's a pleasure. Thank you very much indeed.
Chris.
Thank you.
Thank you.